Here are two images of lumbar shifts. What do you think is causing them? The same thing or different things? And what are they, or what is it? I find etymology interesting, and so I'm imposing it on you. One of these words is the English version of the origin word for manubrium. Any idea which? A patient attended post-trauma with dizziness, headache and neck pain should be a physiotherapist's worst nightmare. First, let's look at the relevant neurovascular injuries in the neck. Collectively, they are termed cervical artery dysfunction, injury or disease, acronymized to CAD. They include both carotid and vertebral artery injuries, but vertebral artery ischemia is the more occult, possibly the more common for PTs, and seemingly the most dangerous, providing we're not talking about frank rupture of the carotid. Common to both are headache, neck pain, and a gradual onset of hard and soft neurological symptoms. But the details vary with each and within each. There are a few other symptoms that when taken individually are more common and benign, but when combined put more fear in the mind of the therapist who understands them. So why not simply refer out everybody who has these symptoms? Well, you can, but overwhelmingly, even when complained of by the same patient, they are not caused by a dangerous condition. But if the patient is referred by a physician who tells you not to worry about it, or should you refer to a physician and he says the same thing, it's important that you are able to make the assessment of how safe or unsafe treating this patient will be. You cannot abrogate this responsibility to the MD. The main point of this webinar is to allow you to make an assessment of these symptoms without resorting to using physical exams that require head, neck movements. These are potentially capable of releasing an embolus and making the diagnosis for you. Most of this webinar is concerned with vertebral artery ischemia rather than carotid artery injury, as this tends to be more obvious. But the next few slides will discuss this condition. I have made webinars on headache and dizziness previously, and while I will quickly review the salient characteristics of each that will indicate neurovascular problems, I would strongly suggest that you watch these if you haven't already done so. The picture above depicts the most common referral areas for pain from carotid artery injury. The immediate pain as the artery is injured is felt in the anterolateral neck and may easily be mistaken for a sternomastoid muscle tear, but careful side-to-side palpation of the muscle fails to elicit tenderness. I would suggest that you don't palpate anterior to posterior or try to palpate the artery. But if the muscle is injured, then so may be the artery, so make sure to look for other signs and symptoms, even if the muscle is torn. If you use a stethoscope, you may be able to hear bruit, but given that we don't do this very often, do not take its absence as actual, but more as an artifact of your inexperience. The headache is felt temporally to the forehead and around the eye, and sometimes into the rest of the face. Because the artery accompanies the sympathetic nerve, this may be damaged as well, and there may be evidence of Horner's signs. The photograph of the lady shows the red flushing of the sympathetic nerve disturbance. In this case, it is from Harlequin symptoms, but the signs of Horner's is not always easy to see. The meiosis can be so slight that it's only apparent in a darker room, where the contrast between the normal and abnormal pupils is apparent, and facial flushing can be difficult to see. The meiosis is small and so might be missed. All of this was covered in a previous webinar on headaches. First, let's abandon the 5 Ds as identifiers of VBI. There are actually about 12 Ds that can be caused by ischemia, and whichever 5 you pick are rarely sensitive for VBI except for dizziness. On top of which, neurological symptoms are an extremely uncommon accompaniment to traumatic VBI in its early stages and can take hours, days or weeks to manifest themselves, so they are not of much use to us. Second, the presence of any central neurological symptoms, regardless of what pathology you are contemplating, but it should be enough to have you referred to the ER. So D's, F's, X's or any other letter you want to use is irrelevant. Third, the 5 Ds leaves out the second most common symptom of VBI, and that is headache, presumably because it doesn't begin with a D. So we concentrate on symptoms that are common for sensitivity, and we allow the specificity of the diagnosis to be made with imaging. Headache, dizziness and neck pain are symptoms of vertebral artery injury, but none are uncommon with trauma. However, other things much more commonly cause these symptoms than does the vertebral artery. The headache is usually referred from the neck. The dizziness is often cervical proprioceptive upset or labyrinthine concussion, and the neck pain comes from damaged tissues as well as other benign and not so benign conditions. But vertebral artery injuries, though uncommonly manifested, are together with high cervical fractures and intracranial bleeds among the most serious. We are going to look at this combination of symptoms in this week's webinar: headache, dizziness and neck pain and their interrelationships in vertebral artery ischemia from injury. While all three symptoms are reasonably common in post-traumatic patients, it is how they combine that may give clues on how safe it is to continue to a physical exam and how urgent is their referral to an MD. Some studies suggest that the vertebral artery may be damaged in as many as 10% of people in MVAs. Most suffer no long-term consequences. The injuries are usually intramural tears that will heal within about 6 weeks without embolus, and that any blocks in the blood flow is generally compensated by the contralateral artery and carotid arteries via the circle of Willis. But if there is a significant anomaly, such as an abnormally small or absent contralateral artery, hypoplasia or absence, or if the artery does not inject to the basilar artery, atresia, then there may be consequences. About 10% of the populations have one or another of these anomalies. So if 10% are damaged and 10% of those have significant anomaly, that means that only 1% are liable to have a serious effect. And this seems high. The other issue is release of an embolus that blocks an important end artery. That cannot be compensated for except by collateral circulation, and there may not be enough time for this to occur. It may be that emboli are not released more often because the patient is unable to move their neck very much due to the cervical pain. But we shouldn't encourage release by moving the neck too early, otherwise the diagnosis is likely to be made for us. The typical headache from VBI is posterior, principally occipital and upper cervical. It may be unilateral or, more disturbingly, bilateral. The patient feels it in the bone rather than deep inside the head and is able to clearly demonstrate with his or her hand exactly where it is felt. The headache is coupled with dizziness and may be coupled with neck pain, as the movement that occludes the damaged artery and decreases blood flow to the hindbrain may be a painful movement for the neck. In effect, the headache and neck pain exactly mimic spondylogenic headache and neck pain, so differentiating from this symptom alone is pretty much impossible. And I'm not going to make life easy for us by discussing the presence of neurological symptoms. If these are present, then you really don't have any difficulty formulating an action plan. It gets referred to the ER. But neurological symptoms are an unusual accompaniment of a vertebral artery injury in the first instance and may take hours, days or weeks to manifest, so we will take the worst case scenario. The type of dizziness that we're interested in for the purpose of identification of VBI are central, either vertigo or pre-syncope. It is true that an embolus that blocks the labyrinthine or internal auditory artery will cause a peripheral neuropathy, but this will be a very rare event and may be unavoidable. Another issue is atypical presentation of dizziness, which may result in misidentification of central dizziness, but this should be compensated for by completion of the following assessment. Generally, we are looking for persistent, mild to moderate and dizziness that is consistent in direction with vertigo, or persistent or worsening pre-syncope. And of course, if either is accompanied by neurological signs or symptoms, then your course of action is clear. Neck pain should be what you typically see with a cervical patient, particularly a traumatic patient. The quality should be sharp with movement or aching with prolonged positioning. The patient should be able to clearly define where the pain is, and it should be superficial in the bone rather than deep in the head. The problem is that VBI headaches feel much the same. So relying on the patient's description really isn't enough. But any oddities such as neuropathic pain, spreading pain, and so on should be considered abnormal, and extra care should be taken with this patient. For the most part, we're looking for evidence of neurological involvement with these symptoms. If any is found, it does not mean that the subjective exam should be stopped. The more information you give the physician, the better, but your bias should be leaning further towards VBI and further away from spondylogenic causes. The main issue in differentiating is less with the dizziness than it is with the headache and neck pain. The headache and neck pain of VBI is essentially the same as that for spondylogenic causes. Because of the similarities between the two, and the difficulty in determining if type 2 dizziness is central or peripheral, you have to rely on how the symptoms relate to each other and how they behave. The symptoms can be local or referred, and I use the term referred loosely to include dizziness as a referred symptom for this purpose. The sources are the neck, tissues made ischemic by vertebral artery occlusion, the vestibular system, and the head, and these are also the referral tissues. Like nearly all referred pain, these symptoms are present when the source's intensity is greater and are directly proportional to its intensity. As a familiar example, pain referred into the arm is more severe and more distal as the source of tissues pain increases. So what we are looking to do is see if the symptoms are linked, that is, coupled, or unlinked, decoupled. This diagram depicts how the three symptoms interact with each other. The symptoms can be caused either by local circumstances such as fractures, inflammation, neurological or meningeal tissue injury, neurophysiological effects such as proprioceptive disturbance upsetting balance and resulting in dizziness, and non-local effects such as referred pain and ischemia. We will make some assumptions. These are mostly borne out by evidence. Traumatic VBI is always associated with dizziness of one type or another. Headache is the second most common symptom of VBI and is almost always present, and we will take steps to make the correction if it is not true. While you can't really say that dizziness is referred pain, it acts as if it is, so for simplicity's sake we will treat it as if it is referred. For process sake, we will make a hypothesis, a falsifiable assumption, that the headache and dizziness are referred from the neck. And finally, we will make the assumption that, as in most cases, not all, that the neck pain will always be present when its referred symptoms are present. There are uncommonly times when only the referred symptoms are felt, but not only is this rare, but ignoring it will only make us err on the side of safety. Using these assumptions, we can predict the behaviour of the dizziness and the headache. The statements on this slide are based on how referred pain typically behaves, and once again, if the assumption is untrue in a particular case, it will mean falsely identifying something as serious when it is not, considerably better than identifying something as benign when it is not. Okay, now we can ask our questions. The primary and main question is, do you ever get dizziness and or headache without neck pain? With the usual exception already mentioned, this should not happen if they are of the same source. So it would suggest strongly that one or other or both are not referred from the neck. Similarly, we would expect that referred symptoms to be present when the neck pain was worse. So if it comes on during mild bouts of pain, then there's a reasonable chance the headache or dizziness is not referred unless the mild pain persists for a considerable time. If the headache comes on independently from the dizziness, there's a good chance that neither is caused by vertebrovascular ischemia. If different triggers bring on the headache and dizziness from those bringing on only mild neck pain, then it is likely that they are not referred from the neck. And if the neck pain improves, either short-term or long-term, but the headache dizziness remains the same or worsens, then referral is very unlikely. If all three symptoms are caused by the cervical injury, then all symptoms will be coupled and there will be minimal decoupling. The headache and dizziness will always be coupled. Both symptoms will be present only when the neck pain is present, but not necessarily every time there is neck pain. Or to put it more emphatically, the dizziness and headache will never be present if there is no neck pain present. However, they will always be present when the neck pain is severe. Over time, if the neck pain is improving, then the headache and dizziness should improve, either in severity or in frequency. But if the neck pain worsens, then so will the other two symptoms. If this relationship is not present, then it's fairly obvious that this is not a referral problem. If the headache and dizziness are coupled, but both are decoupled from the neck pain, then the two are from the same source, but that source is not the neck. This is the worst case scenario. The source is likely to be neurological, and if the symptoms come and go, then it is more likely to be caused by neurovascular compromise. This particular pattern would lead me to refer the patient to the ER regardless of whether I thought the individual symptoms were neurological or non-neurological. This is not something that I particularly want to mess with. This is a confusing scenario, but not necessarily disastrous. Your problem now is what is causing the dizziness, as this has been decoupled from both the headache and the neck. If it is central in nature, if the dizziness is central in nature, then it should be referred to the physician. If it is unstable, that is coming and going, then it should go to the ER. If it was constant, then to an MD if one is immediately available. You can be reasonably certain that there is no headache accompanying the dizziness, therefore it will not be VBI, but you can't be sure. At this point, you should be sure that there is no severe pathology such as a fracture or an ARF, see previous webinars on headache. And you can stress the neck without moving it by transverse shears to cause enough pain to generate a headache. There should be no risk to the artery if no movement occurs, and if headache is generated, then it is cervicogenic. This scenario is similar to the previous, but now your problem is what is causing the headache. If the headache is spondylogenic in nature, then it might be an atypical presentation of a more serious condition, but more likely it would be an atypical presentation of a spondylogenic headache, but more like one than anything else. You know that as the dizziness is coupled with neck pain, the headache is very unlikely to be an atypical presentation of a VBI headache. And as you know that it is not a fracture or an ARF, you can stress the neck as before to make it a little more certain that the headache is not coming from the neck. In this case, you should be able to proceed with a careful full exam and explain to the physician that you cannot be sure where the headache is coming from and could he give you some advice on it. This diagram is how I would proceed with various presentations of the three symptoms. I'll leave it running for a couple of minutes so you can have a good look at it. Manubrium comes from the Latin root man, meaning hand, and properly means that which is held in the hand but is used as handle or hilt because it resembles a sword hilt. So there you go. The first picture on the left is a kyphoscoliosis caused by an L5S1 disc herniation. The second is a Mackenzie lateral shift caused by who knows what, but almost certainly not by a disc herniation. My experience with Mackenzie shift is they tend to be uniplanar, shifting off from the hips, while the disc herniations usually have a large rotary component plus a good deal of kyphosis. To differentiate, if during the exam you attempt to lightly correct the shift and the patient falls over screaming, then it is probably a disc herniation. If they don't, then likely it isn't. In both cases, the deformity is antalgic and will increase pain when you try to correct it, but the degree of suffering is a clue. Also, look for distal referral, severely restricted straight leg raise, neurological signs and symptoms, and lateralization of the pain on shift correction. If there is a rapid improvement in the pain and the shift, then it is unlikely that you have cured a disc herniation, but other possibilities exist because the correction does most definitely help in some cases of severe low back pain and deformity. I hope you enjoyed the presentation. Remember, it's not about diagnosing the condition, but rather in determining how safe it is to move the patient's neck in the next phase of the examination. Thank you for watching.